Now, in the previous lecture, we discussed direct-acting muscarinic agonist drugs, which bind directly to muscarinic receptors and produce their effects. In contrast, in this lecture, we move to indirect-acting cholinergic drugs. As the name suggests, these drugs do not bind directly to the receptor. Instead, they work by increasing the level of acetylcholine in the synapse. They achieve this by inhibiting the enzyme acetylcholinesterase, which normally breaks down acetylcholine. As a result, acetylcholine accumulates and remains in the synaptic cleft for a longer duration, leading to prolonged stimulation of receptors. Therefore, even without directly binding to the receptor, these drugs ultimately produce effects very similar to direct-acting agonists. For example, meiosis, bradycardia, bronchoconstriction, along with increased secretions in the GI and GU tracts. They enhance motility, contraction, and secretion. One more important thing to understand is that indirect-acting drugs increase acetylcholine at the nerve terminals. And this acetylcholine does not act only on muscarinic receptors. It also acts on nicotinic receptors. Because of this, these drugs produce both muscarinic as well as nicotinic effects. Now, focusing on the nicotinic side, increased acetylcholine initially leads to stimulation of skeletal muscles, which may present as muscle twitching or fasciculations. However, if the stimulation is prolonged or excessive, it can lead to depolarizing block, resulting in muscle weakness and even paralysis. So the key idea is that indirect-acting drugs have a broader range of actions because they enhance acetylcholine at both types of receptors. Now let's discuss the first drug, Edrophonium. Edrophonium is a short-acting, reversible acetylcholinesterase inhibitor. It binds to the enzyme through weak, non-covalent interactions, which is why its duration of action is very brief, usually only a few minutes. Acetylcholinesterase enzyme has two important binding sites, an anionic site and an esteratic site. Now, most reversible anticholinesterase drugs bind to both of these sites, which makes their interaction with the enzyme relatively stronger and longer lasting. However, Edrophonium is an exception. It binds only to the anionic site, and that too through weak non-covalent interactions. Because this binding is weak and easily reversible, the drug dissociates very quickly, within minutes. That is why Edrophonium is very short-acting. In contrast, organophosphates bind specifically to the esteratic site, and instead of weak interactions, they form a strong covalent bond with the enzyme, leading to phosphorylation of acetylcholinesterase. This type of binding is very stable, and the enzyme becomes inactivated for a long period. So the key difference is Edrophonium forms weak, reversible bonds at a single site, leading to a short duration of action, whereas organophosphates form strong covalent bonds at the esteratic site, making them long-acting and often irreversible inhibitors. Now, because of its very short duration of action, Edrophonium is not suitable for long-term treatment. Instead, it is mainly used for diagnostic purposes rather than therapeutic use. In clinical practice, it has been used in the diagnosis of Myasthenia gravis, where its rapid but short-lived effect helps in assessing improvement in muscle strength. Myasthenia gravis is an autoimmune condition in which the body produces antibodies against nicotinic receptors at the neuromuscular junction. Because of these antibodies, the number of functional nicotinic receptors is reduced, and in some cases, the receptors are also structurally damaged. As a result, even though acetylcholine is released normally, it cannot produce an adequate response. Due to this reduced receptor availability, muscle contraction becomes weak, leading to symptoms such as ptosis, diplopia, facial muscle weakness, difficulty in chewing and swallowing, and in severe cases, there is respiratory muscle weakness. Now, in this situation, when we administer Edrophonium, it inhibits the enzyme acetylcholinesterase and increases the level of acetylcholine at the neuromuscular junction. This increased acetylcholine can stimulate the remaining functional receptors more effectively. As a result, there is a rapid, within 30 to 60 seconds, but short-lasting improvement in muscle strength. So, if you observe this quick improvement after giving Edrophonium, it is considered a positive test, supporting the diagnosis of Myasthenia gravis. Now, Edrophonium is also used to differentiate between two conditions, myasthenic crisis and cholinergic crisis. Suppose we have a patient who presents with muscle weakness. Now we know that muscle weakness can occur in myasthenia gravis, where antibodies attack nicotinic receptors at the neuromuscular junction. Because of this, even though acetylcholine is present in adequate amounts, it cannot produce a sufficient response. At the same time, muscle weakness can also occur due to an excess of acetylcholine in the synapse. As we discussed earlier, when acetylcholine is present in high amounts or stimulates the receptors for a prolonged period, it continuously activates nicotinic receptors. Due to this persistent stimulation, the receptors become desensitized. That is, they stop responding properly despite the presence of acetylcholine, leading again to muscle weakness. Now, to differentiate the exact cause of this weakness, whether it is due to reduced receptor function or excess acetylcholine, we use Edrophonium. Since Edrophonium is a short-acting acetylcholinesterase inhibitor, it briefly increases acetylcholine levels in the synapse. If the weakness is due to myasthenia gravis, where the problem is insufficient effective stimulation, giving Edrophonium will improve muscle strength for a short duration by increasing acetylcholine availability. However, if the weakness is due to excess acetylcholine, then giving Edrophonium will further increase acetylcholine levels, leading to more receptor desensitization and worsening of muscle weakness. In addition, muscarinic symptoms such as salivation, sweating, and bradycardia may also become more prominent. So in simple terms, Edrophonium acts as a quick diagnostic test. If muscle strength improves, it indicates myasthenic crisis, that is, muscle weakness is due to antibodies. If it worsens, it suggests cholinergic crisis, that is due to excess of acetylcholine. I hope this is clear now. Now suppose we diagnose a patient with myasthenia gravis and we start the patient on Neostigmine, which is a longer-acting acetylcholinesterase inhibitor, which we shortly discuss. Initially, the patient improves. However, after a few days, the patient returns with more severe muscle weakness, along with ptosis and slurred speech. Now the question is, what is happening in this patient? When we start Neostigmine, it inhibits acetylcholinesterase and increases acetylcholine at the neuromuscular junction. At appropriate doses, this is beneficial because the increased acetylcholine can better stimulate the remaining functional nicotinic receptors, leading to improvement in muscle strength. However, if the dose of Neostigmine becomes too high, acetylcholine begins to accumulate excessively in the synapse. This results in continuous stimulation of remaining nicotinic receptors. Over time, this persistent stimulation causes the receptors to become desensitized, meaning they stop responding effectively despite the presence of acetylcholine. As a result, instead of improvement, the patient develops worsening of muscle weakness. So the key takeaway here is that the dose of Neostigmine must be carefully adjusted for each patient. Too little drug will not adequately improve symptoms, while too much drug can actually worsen the condition. In clinical practice, dosing is individualized and titrated based on the patient's response rather than fixed strictly to a single value. The goal is always to achieve optimal muscle strength without pushing the patient into cholinergic excess. Now, let's move forward and discuss another important drug, physostigmine. One key point to remember about physostigmine is that it is a tertiary amine, and because of this, it can cross the blood-brain barrier. To understand this, recall that nitrogen can form three bonds. When it is attached to three organic groups, we call it a tertiary amine. These compounds are generally more lipid-soluble and remain relatively uncharged, which allows them to easily cross biological membranes, including the blood-brain barrier. On the other hand, drugs like neostigmine and pyridostigmine are quaternary ammonium compounds. This means that the nitrogen atom forms 4 bonds and carries a permanent positive charge. Because of this charge, these drugs are highly water-soluble and cannot cross the blood-brain barrier. So physostigmine, being a tertiary amine, can enter the central nervous system, whereas neostigmine and pyridostigmine, being quaternary compounds, are restricted to peripheral action. One of the most important uses of physostigmine is in the treatment of anticholinergic toxicity, such as poisoning with drugs like atropine or certain antihistamines. In fact, physostigmine acts as an antidote in atropine overdose. Now, what is atropine? Atropine is a muscarinic antagonist that blocks acetylcholine activity at muscarinic receptors. Also, because it is lipid-soluble, it can cross the blood-brain barrier and affect the central nervous system. As a result, in cases of atropine toxicity, patients can develop central symptoms such as agitation, confusion, delirium, hallucinations, and even coma in severe cases. In addition, the peripheral symptoms seen in atropine toxicity are essentially the opposite of muscarinic receptor stimulation, as it is muscarinic antagonist. Normally, activation of muscarinic receptors leads to effects like increased salivation, bradycardia, meiosis, and increased urination. However, when these receptors are blocked by atropine, the opposite effects are observed, such as dry mouth, tachycardia, dilated pupils, and urinary retention. So in this situation, we need a drug that can not only increase acetylcholine levels, but also reach the brain to reverse these central effects. That is why we use physostigmine. Since it is a tertiary amine, it can cross the blood-brain barrier and increase acetylcholine levels in the CNS, thereby reversing both central and peripheral symptoms of anticholinergic toxicity. On the other hand, drugs like neostigmine cannot cross the blood-brain barrier, so they are not effective in treating the central symptoms of atropine overdose. Now, coming to the dose of physostigmine in atropine overdose. In clinical practice, physostigmine is given slowly by intravenous route, usually in a dose of about 0.5 to 2 milligrams in adults, administered slowly over at least 5 minutes. The dose can be repeated if needed, depending on the patient's response and recurrence of symptoms. In children, the dose is lower and adjusted according to body weight. An important point to remember is that physostigmine should always be given slowly and under careful monitoring, because rapid administration can lead to serious adverse effects such as bradycardia or even seizures. Some standard references emphasize that dosing should be titrated based on clinical response rather than giving a fixed large dose at once. In addition, physostigmine can also be used in glaucoma, where it increases the outflow of aqueous humor by causing meiosis, thereby reducing intraocular pressure. However, its use in glaucoma is now limited due to better alternatives. Now, let's move to neostigmine and pyridostigmine, These are both reversible acetylcholinesterase inhibitors, and unlike physostigmine, they are quaternary ammonium compounds, so they do not cross the blood-brain barrier and mainly act on the peripheral nervous system. The most important use of these drugs is in the treatment of myasthenia gravis that we discussed earlier. Pyridostigmine is usually preferred for long-term management because it has a longer duration of action and fewer side effects compared to neostigmine. Just like bithanicol, which we discussed in the previous lecture as a direct-acting muscarinic agonist, neostigmine is also commonly used in conditions like post-operative ileus and urinary retention. In these conditions, it works by increasing acetylcholine levels, which enhances smooth muscle activity in the gastrointestinal and urinary tract, thereby improving motility and bladder emptying. Now, another important use of neostigmine is to reverse the effects of non-depolarizing neuromuscular blockers. Non-depolarizing neuromuscular blockers are drugs that block nicotinic receptors at the neuromuscular junction and prevent acetylcholine from binding, which leads to muscle relaxation or paralysis. These drugs, such as vecuronium or rocuronium, are commonly used during surgeries to produce muscle relaxation, facilitate intubation, and improve surgical conditions. Now, once the surgery is over, we need to reverse this muscle paralysis so that the patient can breathe normally again. This is where neostigmine comes in. Neostigmine inhibits acetylcholinesterase, thereby increasing the level of acetylcholine at the neuromuscular junction. The increased acetylcholine can now compete with the blocker and displace it from the receptor, leading to recovery of muscle function. Now, can we use physostigmine in this situation? The reason is that physostigmine crosses the blood-brain barrier and can produce central nervous system effects which are unnecessary and potentially harmful in this setting. So, the neostigmine is preferred because it acts where we need it. Now let's move to another group of drugs, Rivastigmine, Donepezil, and Tacrine. These are centrally acting acetylcholinesterase inhibitors, and because they can cross the blood-brain barrier, their main use is in the treatment of Alzheimer's disease because there is a deficiency of acetylcholine in the brain due to degeneration of cholinergic neurons. It is a progressive neurodegenerative disorder, which means that over time there is gradual loss of neurons in the brain. In the early stages, the disease mainly affects areas involved in memory, particularly the hippocampus. So patients initially present with recent memory loss, such as forgetting recent conversations or events. As the disease progresses, it spreads to other parts of the brain, leading to impaired judgment, difficulty in language, disorientation, and behavioral changes. In advanced stages, patients may lose the ability to perform daily activities and may even develop severe cognitive and functional decline. In Alzheimer's disease, neuronal damage occurs due to both amyloid plaques and neurofibrillary tangles. Amyloid beta plaques and neurofibrillary tangles accumulate in brain regions rich in cholinergic neurons, especially the basal forebrain, which projects acetylcholine to the hippocampus and cortex. These pathological changes trigger neuroinflammation, making cholinergic neurons particularly vulnerable. Now, drugs like Rivastigmine, Donepezil, and Tacrine work by inhibiting acetylcholinesterase in the CNS, which increases the level of acetylcholine in the brain. This helps to improve cholinergic transmission and can provide symptomatic relief, particularly in memory and cognition, although they do not cure the disease. Among these, Donepezil is commonly used because it is better tolerated and has a longer duration of action. Rivastigmine is also widely used and has a slightly different feature. It inhibits both acetylcholinesterase and butyrylcholinesterase. It is available not only in oral form but also as a transdermal patch, which helps reduce gastrointestinal side effects and improves patient compliance. On the other hand, Tacrine is an older drug and is now rarely used because of its significant adverse effects, especially hepatotoxicity.